In this clinical scenario, we have a 63-year-old male with atrial fibrillation. He's on the cardiac wards, and so he's in atrial fibrillation, unstable. So he was placed on a heparin drip at this facility, and he was noted for low platelets. So another fact that you would want to know is, and the questions you're talking to me is, how long has he been on heparin for? We're going to say 5 days. So what is a potential diagnosis that we have? Just think about it before we get to the next part of the lecture. So we're discussing heparin-induced thrombocytopenia, HIT. And there's two types of HIT. Type 1 is a non-immune, and you say, what's going on with this? This is timing is usually 1 to 4 days after initiating heparin. And antibody status, there's no antibodies. Platelet count is greater than 100,000. Clinical outcome in action, no thrombosis, no need to stop heparin. And let's talk about it. It's a direct platelet effect of heparin on factor 4 on the surface, causing mild clumping, but not antibody formation. It's not immune. It's just a direct pharmacological effect on the platelets, not an autoimmune response. Very important. Timing occurs within 1 to 2 days of heparin administration. And it's mild and transient. Platelet count slightly drops, rarely below 100,000, and it returns even if the heparin therapy continues. There's no clotting risk. This is the important thing. Unlike the more serious type 2 HIT, this condition isn't associated with dangerous blood clots. Now let's talk about type 2. And this is important. This is dangerous. This is life-threatening, where we have autoantibodies to platelet factor 4 in heparin complex. Usually the timing occurs 5 to 15 days after starting heparin, and that's what we discussed. This patient had been on heparin for 5 days. Mechanism is caused by autoantibodies to platelet factor 4, complex with heparin. Risk for unfractionated heparin is 1 to 3%. For lower risk for low molecular weight heparin is 0.8%. So that's why you see a lot of facilities go to, or a lot of providers order low molecular weight heparin instead of unfractionated heparin. Now let's talk about the 4T scoring system. And you say, why do we need to do this? We're going to send some labs out. Well, the lab we send out, that's the important one that helps us. In most cases, it takes time for it to come back. Depending on what part of the country you're on, what lab system you're using, sometimes it takes about a week to come back. So you don't have that time to kind of figure out what you're going to do for your patient. How are you going to treat that patient who's there in front of you? You can't go, well, it's going to be a week before I get the lab, so we're going to continue what we're doing. And it can cause harm to you, but we're good to go. And give them a big thumbs up. No, you can't do that. So this is where we start to use information that we can do bedside and basically do a calculation. This is the 4T scoring system. And basically, you can go through this, and there's multiple calculators out there similar to this. This is one that's probably used more than others. And you can use this on any of your calculators that you have on your tablet or phone device. And what you're doing is you're getting a scoring system. In this one, we have a high probability if we have 6 to 8 points. So you're just basically going through and you're looking through, is there thrombocytopenia? When did they fall, giving the time period? Is there thrombosis? And other causes. So how would you know, is there other causes that could be apparent for this patient? Maybe they have malignancy, and that can cause us to have a high probability of having clots. Thrombosis you would see possibly on CT imaging or DVT ultrasounds. A high probability would be 6 to 8 points, and this scoring system intermediate would be 4 to 5 points, and then low probability is less than equal to 3 points. So this would give you an idea of what action you need to take for this patient. Let's continue our discussion on heparin-induced thrombocytopenia. Now remember, in heparin-induced thrombocytopenia, we see a 30% risk of thrombosis. About 75% of them will be in the venous system and 25% in arterial. What are some risk factors? We're going to say heparin greater than 4, 5 days. 5 days is probably more correct. If patient has had surgery, increased risk. Using heparin, unfractionated heparin instead of low molecular weight heparin. So what is a diagnostic indicator? Would be platelet count greater than 50% from baseline. It's suggestive diagnosis. Now you said, why did we use that scoring system? Well, the gold standard for determining for if patient is having HIT is the ELISA for PF4 heparin antibodies. And this is a functional assay. It's a serotonin release assay. It's the gold standard. Now, it's a technically challenging test that requires special handling of platelets and radioisotopes, which limits its accessibility and increases turnaround times, meaning it takes time for it to do. And there's not that many places to do it. So depending where you are in the country is you may have to send it out so you have the transit time and the time it takes to get the answer back. But also the test itself is a little bit challenging. So the donor platelets are incubated with a radioactive serotonin, just like Spider-Man radioactive serotonin, right? And they're taken up and stored in the secretory platelets. And then the platelets are washed and removed to remove the excessive radioactive serotonin. That's a radioactive tracer that's placed on the serotonin. The serotonin release assay generally takes about 2 to 4 days for the analytic time. With the turnaround time, the specimen, it can result sometimes 3 to 7 days. Now, if you add a holiday into those mix, it takes a little bit longer. I know it's not supposed to, but it does. It does take longer in the holidays and that dirty word weekends. If you send it out, it may not get there during the weekend and it may not be worked on. I know it's not supposed to, but it does. So this is why you have to say, what am I going to do to treat this patient, because I'm not going to get the serotonin release assay back right away. Now let's talk treatment for a hit. That's why we use a scoring system, because it's going to take time for that serotonin release assay to come back. So then you come up with your plan of action. And the first thing you're going to do is initiate an anticoagulation. So you're going to stop the heparin. Number one, stop the heparin. Stop the heparin. And then you're going to initiate anticoagulation with a direct thrombin inhibitors like Pyridine, Agatroban, bivalirudin. Those are your ones again. Now, then you would initiate a transition phase. But here again, let's go with what the new evidence is, DOACs. Now, this data from 12 publications across 36 patients. So not robust data, but it's starting. The DOACs are an acute phase of HIT, may be safe and effective treatment option for patients. Now, initiating DOAC does not require platelet recovery. So we'll go back to this and transition when the patient is clinically stable. So when the patient is stable, you initiate the DOAC and there's no overlap. You start DOAC within 2 hours of stopping one of the direct anticoagulations, your direct thrombin inhibitors. Pretty nice, because it can take some time for these patients to get them out of the hospital. So let's go back to the old school ways. We initiate the direct thrombin inhibitors. We have a transition phase and we wait for the platelets count become greater than 100,000. Then we start warfarin for 4 weeks. And then you're going to determine how long you're going to continue the warfarin for. Now it says no heparin for the next 6 months. Now this may be years, because they may hold on to the antibody. So it can be years or never starting heparin again. So this is how you would treat someone with HIT, and to get them back into the game and get them back home.